If you have a lot of certainty in something that is potentially equivocal, I could do this or this and you'll get the same outcomes. But if I feel really confident in that, I have better outcomes than the person who's uncertain. So what I have come to lean into is,
what if the thing making you feel like a fraud as a clinician is actually the thing that could make you great? Today I'm talking with Richard McIlmoyle, a chiropractor from British Columbia who spent 13 years practicing with biomechanical certainty before everything changed. After discovering modern pain science, Richard went through what he calls an existential crisis. And on the other side of it, he became a better clinician, a better mentor, and someone who's now influencing how medical students learn about pain. In this conversation, we dig into how to mentor students without shattering their confidence, why intellectual humility might be your greatest clinical asset, and how Richard approaches manual therapy from a macro down perspective, starting with values and beliefs before ever thinking about tissues. We'll also talk about the tension between contingent education that sells certainty and the messy reality of clinical practice. And Richard shares the story of how he audited UBC's medical school pain curriculum and how he's working to improve how healthcare understands and treats pain. This is a conversation about transformation, humility, and what's possible when we choose curiosity over certainty. Now, on to our conversation with Richard McIlmoyle.
This is the Modern Pain Podcast with Mark Cargilla.
I appreciate you taking some time. I'd love to hear you, because I have some good friends who are chiropractors, and the journey, and I've also had obviously a very heavy manual therapy background myself. I'm wondering how your journey evolved and some of the existential crises you faced along the way to get to where you are from like your initial chiropractic training.
Yeah, excellent. That is a fabulous question. And everybody that I ever met down in San Diego went through that whole process of shedding our former selves and emerging the other side, from the cocoon of what we were. So I graduated in 99 from a school, Logan College of Chiropractic out in St. Louis, Missouri. And, that experience of being thrust into a world which I didn't understand when I first went in. I had seen a chiropractor back in my high school days, and he had done some work on me, and I had some knee pain, and he sort of assessed my pelvis and did some things, and my knee pain got better. And I thought, wow, that's really cool. I'd like to learn how to do that. And so that's what prompted me to go to school. And then I found out about all of the interesting stuff that happens in our profession. So after graduating, off I went, was practicing in Ontario, then moved out here to the West Coast. And it was probably early 2010s. So I had been in practice for, 12, 13 years. And I came across, actually, it was Craig Liebenson, who's chiro down in LA. He wrote the rehab textbook that I'd used in school, and it sort of influenced my approach. Saw him on Facebook, and he was posting some interesting videos, posted the famous TED Talk from TEDx Adelaide that Lorimer Moseley did. And I saw that. At the time, I was also teaching neurology at our local massage college. And the way he described like nociceptive signaling, and when he does that video, there's so many layers to it that really captured me. Like, he speeds up his talk when he's talking about A delta fibers, and then he slows it down when he's talking about C fibers. So he doesn't directly articulate these things, but I liked the underlying messages and how complex it was. So that brought me in, and it triggered me to rethink everything that I knew. That was the gateway into it. And at the same time, my business partner's wife was experiencing some chronic pain stuff. So it really sent me down the rabbit hole of trying to understand that better. And fast forward to 2015, and Lorimer was speaking down in San Diego at the San Diego Pain Summit. And so my business partner and I went down and found our people. It was sort of like, these people are all having the existential crises that we are, that everything that we've understood how what we do works isn't how we work. So you go into the nihilism stage where you say nothing works, and then you come out the other side and go, everything can work. And it came to me pretty easily in that there was always a thing within my profession where, like in school, I leaned hard into biomechanics because that seemed to be the only thing that was really based in hard research within my profession. There's a lot of the airy-fairy stuff on the edges of, you're aware of it, I'm sure, like fixing cancer by cracking joints and stuff like that. So this is where I leaned into. And then, so from a biomechanical standpoint, if I direct forces at a joint in the lower back and your back pain gets better, that makes sense to me. There's some practices within our profession where they just treat like the top two vertebrae. That's all they treat. And you're thinking, well, that's crazy. But then you meet people who've had gotten better with like low back pain issues or, hip issues or knee issues that have just been treated here. So reconciling that from a strictly biomechanical standpoint was untenable. But then the door being kicked open by introduced to how what we do probably more accurately works, all of a sudden that made sense. So there was multiple layers to why it really resonated with me. So, yeah.
Yeah, it's that video. I definitely recall that TEDx talk. That's one I remember when I first listened to it. I was fortunate. I was teaching some adjuncting at a college where I was able to teach pain science. And that one was one I always would clip pieces out of that and played it for the majority of my classes. Still a good video and really still resonates to this day. But you and I both have the opportunities to mentor students who are going through chiropractic training or in my case, physiotherapy training. We both were speaking to this a little bit before we went on, but it's a delicate balance, right? Because I think what we see with modern science and things and how quickly that enters the classroom, for us, it's got to go through accrediting bodies and then it's like at minimum a 10-year process. So it puts, as a clinical preceptor or mentor, puts you in a difficult position, right? Where you have a student who's learned all these things that in a very kind of categorical, kind of this illusion of certainty, right? They learn often like A, B, C, or D, or the rubric is very linear way of looking at how things are. And then we've been out for a while and we see how chaotic and nonlinear and complex and emergent pain is, and how there's no training that's ever going to perfectly, you got to get out there with people and just have some concepts and some frameworks to go off of and then figure your way out for yourself and all that good stuff. But I'm wondering how you deal with that tension with knowing what you know and the bumps you've had. And I do wonder sometimes if we just have to go through our bumps and journeys, but how do you help students not completely shatter their foundation of because it's not like we need to completely shatter it. They learn a lot of good things and some good orthopedic skills and exam skills and stuff. But obviously there's also a lot of things that are like, okay, I understand that's how you've been taught, but here's the reality of what we see with humans in pain. How do you deal with that when you're working with students?
It's a delicate process. Well, I say that I think I deal with it similar to how I deal with communicating with patients. I think there's an overlap there with a lot of not a lot. Occasionally you have people coming in to get treated, looking for your help, that have these foundational understandings about how their body works that are flawed, or at best flawed, no, at worst flawed, at best slightly misunderstood. And, maybe they've been planted there by a previous practitioner that they saw, or just sort of the cultural zeitgeist of things. And you have to challenge those. And it's pretty individual. Like, how hard do you need to challenge them, or how softly can you challenge them? So when it comes to students, I think I've had the good fortune of most of the students that have come to do their preceptorships with us at our clinic have a little bit of a leaning towards questioning some of the things that they were taught. So they're preloaded a little bit. But when it comes to challenging those, I usually lay out scenarios in front of them to try to reveal the questions to ask. If that were true, then why is this? And that's partially how I approach treatment when we're doing, exploration of movement. If someone has a belief that something is inherently flawed, broken, stuck, and then if you can create a situation where that belief is challenged, then it kicks that door open. So a lot of the psychological constructs about creating cognitive dissonance and creating an opportunity to change the narrative that they have. So it's similar with students where, we'll be doing some work in, an assessment with a patient. And let's say you're going through shoulder girdle orthopedic testing, and I'll mess around with people want you to do something to them. They as a patient, you want an evaluation, right? And so as you're going through the evaluation with orthopedic testing, I'll mess around with that to try to show them what they can do. So if there's an orthopedic test that they fail or they have pain with that, slightly modifying it and trying to create a situation where they don't fail with it or they don't have pain. If you're doing like just resisted range of motion stuff with somebody's shoulder and just have them, okay, I'm going to have you raise your shoulder. I'm going to have you retract it or protract it and load this again and see if that changes. When a student sees that, they're like, that's not how you do that orthopedic test. And then you can have that chance to walk through how you've created that change.
I think it's like you're creating almost a behavioral experiment like you would with a patient, right? You're almost, because I think that's a sign of, top-notch like mentoring, right? Because sometimes, and I know earlier in my like coaching, mentoring, it was very much like we say, not to be with patients, right? Where you're just, I'm the expert, you're the student, let me just dictate down to you. It's like trying to meet them where they're at a little bit and then create scenarios where it's not you telling them something, it's where they come up with their own answers through you giving them, this is where you're approaching it, but yet there's this. Mm-hmm. Can you see the disconnect? What do you make of that, right? Where you're having them unpack that a little bit. To me, that's like the most powerful way somebody, can learn, right? Where it's not this just eviscerating mentoring, dressed down because, what are you thinking with that versus allowing them to explore and be curious and, not always have the answers. I think some of that humility too. Do you find that being helpful because I think I've come across some mentors who've been great, but I've definitely had some that maybe were overly certain, maybe would be the words on things to where it was off-putting to me. And especially when I was reading things that are like, I can't really get behind that. But I think like some intellectual humility and goes a long way in that relationship with a mentor mentee. What's been your experience?
I think, being able to say, I don't know, like similar with patients, like, why does that do that? Well, I'm not really sure, but here's a few possibilities. And in the mentorship role, I've always leaned into, a good mentor-mentee relationship is one where almost you're riffing off each other. And there are things like those students who are just coming out of school, there's a bunch of stuff that they know that I wasn't taught or exposed to. So I've learned lots from students that have come through in that, oh, I didn't realize that. And then you go down a rabbit hole and, okay, that is a better way to, if you look at strict orthopedic testing and you're like, oh, here's a triad of tests that if you do those and they're all positive, that gives you a better indication that might be like a source of nociception. And it's just not something that's you can't know everything. That's where I lean into. I can't know everything and I know that I don't know everything. So pretending that I do is a disservice to me, to everyone around me. People are coming in to try to, that's why people see us. They want to try to understand stuff. And if you don't understand it, then how can you help them understand it? I think that's, I think that's great.
Do you think there's a difficulty that being willing to say, I don't know early in your career? I know for me personally, there's such a clutching for expertise and belonging and worthiness as somebody this person should trust and believe in. And there's probably a little bit of some lack of self-confidence and lack of belief in ourselves that we really have to establish ourselves as this expert and all-knowing, which puts us in a situation where, man, it was hard for me to even consider, I don't know, because to me, you're a failure, you don't know what you're talking about, different things. But now to me, I look at, and I've posted about this, if I see a clinician out there who can say, I don't know to a patient, that would be a person I would turn towards and, hey, what's going on here? Versus early in my career, it's if this guy doesn't know what he's talking about. What do you think? As far as, was that your experience as a young clinician as well?
Oh yeah. That resonates with me so much coming out of school, thinking that you know everything. When you're taught, everything you're taught in school is, there'll be this certainty when you come out. If the person has this, you're going to be, catching people's cancer because you are such a good diagnostician. You're going to be able to feed through all of this. And then you come out and nothing looks like it did in school. Nothing's cut and dried. And then there's so much uncertainty and the sense of, geez, am I a fraud? I really don't know what I'm doing here, but I don't want anyone else to know that I don't know. And like the layers on top of that of being, looking young, like I graduated from Chiro College when I was 29, but looked like I was about 22. And so, wearing a tie to try to make myself look more authoritative. And then I had this conversation with my business partner now. She's a chiropractor who graduated in 2016, I think it was. And like the added layer that I think of, not only is she looks young, but she's a woman as well. And like the lack of respect for knowledge that happens there that's fed through her entire career adds another layer to her. So we all come out, I think, with this. If you don't, there's a problem. If you don't come out and then start in practice and go, oh crap, I don't know what I'm doing entirely here, I think there's a problem with that. If you think you do know everything, you're not going to grow as a clinician to try to gain the knowledge to know more about what you're doing. But also, I think you're doing a disservice to your patients to think that you know exactly what you're doing.
Yeah. Do you see continuing education as a clutch for certainty too? I mean, I've just been thinking about continuing education because there are so many gray-haired individuals, maybe more than just gray-haired individuals, because there's some younger folks too, who will sell you certainty, right? You just got to do it. This system that I have, it'll get it figured out. You just got to do this, and then the certainty's there. And then you grab the certainty, you get a little dose of it, and then we know all the non-specifics when your confidence high on it, and then the reality strikes that it is just falling in line with the graveyard of other frameworks and systems that were supposedly supposed to give you this certainty. What's your experience been with the con ed scene overall?
The con ed scene has been an adventure over the years. Like I've, in school did the whole ART thing, came out, and when I came out of the fog of having kids, once my youngest was 3, is when I'm like, oh, okay, I'm not just like rote in practice. Like I look back at that time and think, oh my gosh, I was just a robot, like going through and not having a lot of cognitive space to do anything because you're sleep deprived, you're pulled in every direction. But when I came out of that, I became interested in DNS, so dynamic neuromuscular stabilization, because it was being sold as more of a framework of thinking rather than a process of doing. And that appealed to me at the time. And it continues to appeal to me to like, if you're thinking about any process, have a process of how to think through things and like the critical thinking mode of things. We went through all of that, and then it's just, it's one thing after another of here's the system to go through. I haven't done, was it MDT that they call, like used to be McKenzie. I don't know if there's a difference between those, but a lot of people that I find have a lot of certainty when they do that. That's and I don't know, what is the latest one? I don't know.
Yeah, I don't know. I think dry needling and there's a big push here, and there's a few other things. Manipulations remains huge and always will. And again, none of these, I just look at things too as one more thing that can give you the certainty of maybe some short-term changes, which can be a helpful move to start somebody, nothing wrong with it. But again, when we sit there and that's where we anchor our practice and identify with it, then God, you miss so much growth and you miss so much ability to be so much more than whatever system or intervention you are. Like take what's best out of those things, and maybe there's some strong suits to them. Yeah, I think they can have this.
I use stuff from all of the different systems that I've learned in Cont Ed and then just use them for what they're worth, right? There's a big thing here, myoactivation, which I think is like an isolated to BC sort of technique that was developed. It is basically a form of dry needling, but there's a huge uptake from people, and they're like, oh, we're changing fascia, and it's primarily in the medical realm. So it's MDs and nurse practitioners who are getting heavily into this. And so all these, there's a benefit. Some people have huge success with it. You see patients go in and have it done, huge success. And so you can't discount the thing that's being done. I think we've all talked about this in the past. Like it's the framework, the understanding about how it works. That's probably not exactly how it's being shown.
I always have this internal struggle because I have this like maybe skeptical nature a little bit. Those of you know me probably definitely know that, but it makes me wonder if I could just be blind to just drink the Kool-Aid and have the zest and because if you have that going into an intervention, you're going to be like selling it like you believe it, like the truth, gospel truth of what's going to be. This is what you need. This is what's going to. And I sometimes wonder if I compromise outcomes by not I just, with a good conscience, I can't, propose the changes or the grandiose claims that some of these things. Do you find yourself struggling with that? Like, you see folks out there who have their system or things, and it results in somebody who is massively confident, that has really a practice theatrical ritual around whatever their shtick is, around whatever the thing is, that probably accounts for the majority of the mechanism of effect. Yet, I sometimes wonder if I miss out on that. What do you think?
Yes. And I mean, there's a component of that, like the missing out on it, that also emerges from when you're trying to practice the way that I hear you're doing it and the way that I try to do it. If you're in a system and then have the doors open or the curtains pulled back on understanding the mechanisms, almost everybody that I've talked to in San Diego and in other places, when they've gone through that, financially you take a hit because of the uncertainty and all of that, and you're not treating people within the system anymore. So there's a lot of chiros who fall into systems and they're just churning people through. You see them, buying the yacht, buying the big cottage on the lake and all of that. So there's a little bit of feeling of missing out with that. But then you look, Bielowski and Bishop did studies on, if you have a lot of certainty in something that is potentially equivocal, I could do this or this and you'll get the same outcomes. But if I feel really confident in that, I have better outcomes than the person who's uncertain. So what I have come to lean into is my certainty in A, uncertainty, but B, that there's options. Like, we can find the things together to help move forward. So I'm confident in my ability to communicate with a patient or client, whichever terms you want to use, to navigate. Like, I know I have confidence in my skills in communication that we can chart a path forward. Whether I will be the successful person to guide them or not, I know that we can uncover some things in some way to help them. Like, I feel I've done this a few times with people just to sort of take the piss out of them. It is like, I can with 100% certainty tell you that I will help the person who comes through my door. And sort of cheekily, we'll figure out if there's something we can do or can't. Right? So, which is helping in some way, shape, or form.
I like it because you're leaning into that uncertainty. Is like, this opens up options, right? It gives us a lot of ground we can cover to find out what works for you. And I think that's where I think I've landed on it as well. To me, it frees me from having to be beholden to a system, right? And I still see, I have colleagues and stuff where they're going to the same manual therapy conference year after year. And I think, what a shame to limit yourself to, granted, they'll bring in some lip service of some other things beyond just the manual therapy. So I get it. Yeah, we do it. We have that in there. It's in the conference. This guy talked about it today, blah, blah, blah. Yes. I just think, what a shame to limit yourself. And I think just being able to lean into that uncertainty, because I think when you anchor to a group or a system, you anchor on a false sense of certainty that really limits your ability to navigate what the reality is that you face
in the
clinic. And I think it's a shame.
The different people that you learn from, this is, in retrospect, one of the things about, I keep on bringing up San Diego Pain Summit because I loved what happened there in the breaking down of barriers, the breaking down of siloed education, right? No one knew I didn't have chiropractor across my chest. You didn't have physio. So no one knew your backgrounds, but also I was exposed to speakers that I would have never chosen to go see. It's like a lot of the psychological constructs, a lot of the things from OT, like Bronny and different things, I would have never chosen as a standalone to go and learn those things. But being exposed to them in that setting revealed to me how much understanding that can make us better clinicians. And so I feel also sad for those people who don't go outside of they're in their pocket and that's what they do. They just do that over and over again. So I think one of the things I like to try to do with continuing education when I teach is, can I Trojan horse this? Can I give you a course on manual therapy, but I'm really trying to break down some of your biases and understanding about that. So yeah,
It's a tussle for sure. And I just would encourage you, if you're listening and you're considering, I'm going to just go to the same manual therapy conference where I get my reinforcing dose of confirmation bias, that you just get unstable, just lean into that uncertainty and go to a psychology conference or go to even an occupational therapist. Like, one of the greatest underestimated professions out there is occupational therapists, as far as their ability to really work with people and move them towards what matters, not get caught up in the techniques and tools, and really lean on what the human in front of you has as resources and all that stuff. One thing I wanted to touch upon is what we talked a little bit before going on, is how your system of how you can decide on manual therapy and kind of your framework you use. Because I think it really is similar to how I think of it. And I was just having a conversation of, instead of going micro to macro, we go more macro and then see what needs to happen micro. Because sometimes it's the macro stuff that if we handle that, maybe we don't need to get as micro with a lot of the nitpicking on mechanics and things that maybe have been traditionally the way we look at it. I love if you can unpack your thought process around that and how you look at it now.
I feel like I turned the pyramid upside down. Instead of going from a small, how we're taught, try to figure out what tissue is causing the problem and then work out from there, and then understand, are there any barriers, psychosocial things to create barriers to success? I think my approach, and this is how I'm trying to build out to teach folks about it, is, if you're doing an intake and you start having those conversations and you're really trying to understand their belief system, what are the factors that are playing a role in their life that might have brought them to this point where their pain experience is enough that they're seeking care. That's one of the things Ben Cormack said this once in a course that he was teaching here. He asked, why do people come in to see you? And a lot of people say, because they're in pain. And he pointed out, they don't come in to see you because they're in pain. They're coming out to see you because the pain is now interfering in their life, or they're worried it's going to interfere with their life. I want to do that thing, and this pain isn't going away. I want to do that thing. So that's sort of part of the premise. So what do I have to understand about the person in front of me, about what it is, so you can understand goals. So understanding a lot of that, and then understanding their beliefs about what is going on in their body. And then the fact that biomechanics and beliefs, and if you want to break biopsychosocial, I really don't like that term because it does isolate everything. It does, and I argue that it's a model. It's really a framework. Models predict things, and this framework is just, to me, biopsychosocial as a framework is how do we understand how humans work, right? So there's all of these different components that are wound together. And so when we start to understand what's going on with the person, we may be able to understand why they're moving a certain way. If their beliefs are that their thoracic spine is crumbling because someone took an x-ray and told them they have degenerative disc disease and all these different things that they take on as meaning they're falling apart, they're going to move differently. So there's the tie-in to biomechanics and thoughts and beliefs and cultural ideas that I think if we start from the top and understand all those cultural ideas, beliefs, and everything, then we start to get into some manual testing of people, and we can unwind the parts of it that are, fear of movement, habits of movement, take those things away and see if we can change a person's beliefs about what goes on with movement. And then we can bring it down to go, okay, there is a tissue-based symptom here. So we've gotten rid of the fear of movement, like someone's afraid of moving their neck. And let's say you get rid of all of their fear, do some passive stuff. And then you get to the point where, I can repeatedly put your head into this position passively, and you get a sense of pain in that area of your body. Maybe there's something being pinched there that is the origin of nociception. You became sensitized around it because you repeatedly triggered this nociceptive. Maybe you have some nervous system changes that expanded that, and now your body is bracing. You're now afraid that you don't want to trigger that painful experience. You think something's broken. And if we can unwind all of that first stuff to get back to the original or the tissue thing, we've gotten rid of all of that other stuff first. And it makes it so much easier to then get in to treat this. And you can explain it as you go with the patient.
That's that whole making sense of pain that, Peter O'Sullivan's group does such a good job of. And I think I 100% agree. I think sometimes it allows you to get a lot of the compensatory or the kind of secondary, changes that happen from, dorsal horn to the brain and all the movement patterns and different things and emotions and thoughts and beliefs and all that stuff. And sometimes when you address that stuff, you're left with a very kind of specific mechanically patterned pain behavior that would suggest nociceptive things that would benefit from maybe more specific things. So lo and behold, you might treat very locally and specifically at that. I know that gasp from the audience where you might actually do a manual technique at the spot. Now, and that happens, right? But I think obviously we don't go with the assumption that it needs to happen. But I think the other interesting thing that I've seen, and I love to hear, is sometimes you take care of, and I see this with Peter stuff, and I definitely see it in clinic, where you take the fear and you work with some of that, movement behaviors, different beliefs and stuff, and behavioral experience, and all of a sudden there's no need to do anything to tissues because things are moving and doing great, and life's good. But I think having a process that can go from that big macro, what's your values, what's the thing that this person's, like you said, limited in life that's they want, and then get back, well, what are the things that are getting in the way of that, and not getting immediately to so micro tissue level of looking big picture, because you can start knocking those things down. Maybe it's through some pain neuroscience education, of course, coupled with other things. Maybe it's through some other things that are exposure-based work or some behavioral experiments that you knock those things down. And then, man, the tissues, why monkey with them? The person's happy as a clam. They're moving great. Has that been your experience too, where it gives you a little bit of a filter of when do I need to worry nociceptively tissue-wise versus making that assumption it just needs to happen from that, like you said, impairment specific tissue, then go to the big picture?
100%. I can't tell you how many times I've had somebody come in and see me. We walk through all of this and I could do nothing to them and they would be fine. There's no need for me to do any sort of manual intervention to them. The testing and everything that I did, touching and moving their body around, is probably enough. The secondary layer to this is, again, you think about like biopsychosocial, the social construct that we exist in Canada when it comes to healthcare is it's free, but they have to pay to come and see me, right? I'm not covered under our provincial plan. And so there's expectations that they come in with. And because I have this title of chiropractor, many people come in with the anticipation, with the expectation that I'm going to do something to them. Unless they've been referred from somebody who's had the experience with me where we haven't had to, or the main benefit has been not what I do to them, but how I've coached them through things, I do something to pretty much everybody. Like I do some sort of manual therapy to pretty much everybody because of that patient expectation. But it's always couched in, we're going to do something to try to change how you feel about this part of your body for a period of time so that then you can go and do all this stuff. But this is like a temporary little change. And one of the things one of the things I was teaching, just doing this new sort of course on the weekend, was my question to the audience was, what is the goal of our treatment towards people? It was a room of chiropractors. And so you get rid of pain, you get all these different answers. And I would assert that our goal is to change the person's perception of their own body or their perception of self, right? Like even moving from, one of the examples I used was there's a woman who came to see me several months ago, was having some ankle pain. It had been going on for a year and a half. She had seen a few different people. Someone said, go see Richard. She came in to see me. We did an assessment. She identified as a runner and hadn't been running for about a year and a half. She had a daughter who was about 5 or 8 years old, somewhere in that ballpark, who was getting into running. And the patient wanted to be able to run. There's a local race that's a marathon, a 10K, and they have a kids race that's like a 1K race. And she really wanted to do that. And so we assessed her ankle. All I did was say, everything I'm seeing here, there's no reason why you shouldn't be able to get back running. And that was the treatment. She just needed the assurance that her body would be able to do the thing that she wanted to do. Barely did anything. Most of it was assessment and just said, I don't see any reason why you shouldn't be able to do this. maybe did a little bit of mulligan type stuff just to make her feel a bit better. And yeah, and she got back running. I think I saw her again 3-4 months later. She had done the run with her daughter. And the reason she was in to see me was because her and her sister had gone for a trail run and gotten a little lost. So they ended up doing like a 10K run instead of 5K. And she's, I think I overdid a little bit. Can you have a look to see if I'm okay? Like, those stories are many, right?
Yeah. It's a great example. I think sometimes we have this preconceived belief that we need to go in there and intervene and do something, right? And I think sometimes our best treatment is reassurance that you're safe, you're okay, you have been the ritual of thoroughly being looked at and thoroughly being examined and feeling like, no stone has been left unturned, and you have given me all systems go, I am safe to engage. How many times and I'm just hearkening back to my career, I wouldn't even have thought of that. Like, it was immediately like, what are we going to do? Right. And I got to imagine there are people I have missed along the way that simply needed reassurance and a good, solid physical examination that really signified thoroughness and that things have been really exhaustively checked and you're okay on with life. And do you feel like you've missed some of those along the way?
100%. Like, I can probably stop and think about 3 or 4 just off the top of my head, much less the dozens and dozens that I've probably forgotten about. And yeah, that reassurance, the thoroughness of exam, and then the other component, I can't remember who used this term, but a durable narrative for them. Here's the story that we've co-created about why you were experiencing that. Like, because they've been experiencing something in their body that has brought them to see you. And so I think if you just do the exam and you're like, yeah, you're all good, there's no reason why you have that pain, can be unhelpful, right? Can be disconcerting to people. Be like, oh no, it's probably if you were moving I'm just making something up, but you're probably moving differently because you were afraid that you were going to hurt that. So you were probably putting more strain on this tissue or that tissue, but you should be fine. And you can just move more freely, and giving them, again, the permission to move freely and without protection. Then hopefully that narrative is durable, that when they go out into the world and sort of challenge that narrative, it holds up.
That definitely is awesome way to practice, and definitely resonates with kind of, obviously that's why we got you on the show, man. We jive with many things. I'd love to hear, because you had an interesting experience recently, and then we'll land the plane here. You were able to, because this is one thing that I'm trying to find my ways into our medical school. We have a DO school that's in our university that I think could probably do a little bit better on the pain front. It's still very much a structurally dominated narrative around pain, but you had the opportunity to get behind the scenes of medical education and really hopefully make some changes or recommend some changes. I'd love to you share what you did, because I think that's a great thing that I think if more folks like you could kind of get involved and see if you have some inroads to just politely suggest taking a look behind the scenes and auditing things a little bit and seeing if there's some room for improvement.
Room for improvement. Exactly. Well, it stemmed from a talk that I did. I did it twice. I did it once at Pacific Pain Forum over in Vancouver. Then I had a friend ask me to come and do the same talk at the Alberta Pain Society conference. And it really was about siloed care and how do we integrate, like, what's the pathway forward to help create true interdisciplinary care? Because we know that's gold standard for chronic pain. And right now we treat in silos. And my assertion is that we should all learn together and have a common language which would enable us to then integrate care together. And so part of that talk was I went and looked at what is the pain education that we have in our pre-licensure for the different professions. And what I came across was in Canada, in the med schools, dedicated hours to pain education. The highest number in their entire curriculum is 10 hours. I don't know which school it is, but one of them actually has 10 hours of dedicated to pain education. So in my ridiculous boldness of being a chiropractor, actually contacted the University of British Columbia medical program and asked them what they were doing for their pain program, because this is what I've become aware of, and would they be open to having a chiropractor come in to teach a course about pain. and got a response from the curriculum folks. And she said, well, let me send you some things that we use. And so she sent me a couple of links at first, and I watched some videos that they utilize. And it was mostly good, but there was some sort of outdated ideas and some challenging sort of narratives. And so I got back to her and I said, here's a summary of what I saw in that here's the research that supports something slightly different. Then she got back in touch with me and said, hey, why don't you audit our second year? They do pain during this week. So I was able to virtually sit in, because they do a mixed program of in-person and virtual, on 3 lectures that they do that are focused on pain. Over the course of that, there was 3 minutes on musculoskeletal pain. So this is in their entire second year. I don't know how much they get in other years, but in their entire second year, they had 3 minutes on musculoskeletal pain, which felt horrible because I think 80% of patients come in to see doctors, at least here, for a pain thing. And a lot of it is musculoskeletal. So anyways, I got together with a friend of mine who's a physiotherapist who's working with Pain BC as well as with Pain Care BC, which is a provincial arm of the government that's been created to try to help increase the uptake of interdisciplinary care for pain for people in the province. And with her knowledge of how to write things well, and with the notes I had taken, we formulated a recommendation plan for some potential changes to the pain program, or the pain education in the UBC Med program. So there's a benefit to knowing people. I've made some relationships. Tori actually was in San Diego the last year, I think. But to make those connections with different people in different professions, which I've made through our adaptive mentorship network that we're doing with Pain BC as well, with MDs, with occupational therapists, with physiotherapists, with nurse practitioners, having those personal connections opens doors for opportunities like what I got there. So
more folks in this kind of thought process with pain in more modern ways that you need to be making those networking efforts and starting to make those connections, because I think those type of opportunities like you had and if that changes like the education of physicians in BC, that can have a massive ripple effect. So good on you for doing that, man. If folks want to reach out to you, like if there's chiropractors like, man, I want to get mentored by this gentleman. Sounds like he's forward thinking and somebody I'd like to learn underneath. How can folks get in touch?
The website is www.drrichardmcilmoyle.com. And that has all my information on there. I'm also relatively active on Instagram and Facebook. And I think I gave you the links for those things. So I can't remember what the handles are because I just use them all the time. I don't actually tell people what my handles are. So
we'll have them in the show notes.
Yeah, excellent. Yeah. And if anybody ever wants to reach out to me in Victoria, my clinic is Achieve Health. So
we'll link his clinic and all the areas where you can get in contact with Richard in the show notes. Really appreciate your time tonight, Richard. And thank you so much for what you're doing up there in BC. Also a beautiful area to visit if you get a chance to visit up there. You can't beat. Yeah, absolutely. All right, we're going to leave it there this week. I appreciate everybody listening. If you haven't subscribed to the podcast, we'd love you to subscribe to the podcast. Share this episode with somebody. We need more of this information out to more people. We'll leave it there this week. We will talk to you all next week.